So we thought we'd talk a bit about myth busting around low back pain as a common presentation that comes through our service. People have kind of come with these various thoughts and experiences, and we thought we'd kind of pick people's brains on that really. So kind of first one, maybe throw this at you, Chris. What do people often say when you ask them what they think is causing their back pain?
Oh, I mean, there's lots of reasons, I think. The common ones, I think, are things like people say, well, I've got spondylosis, or I've got degenerative change, or I've been told I've got disc degeneration, or I've got a slip disc. All these are really common kind of things that people say, and I think, partly. It's our job to explore those and their understanding of what those things actually mean, because they mean different things to different people. And I think from your point of view, Greg, you probably see similar sort of stuff.
Yeah, that's a really good question. What we do ask patients, what do you think is going on? And I think probably similar sort of answers to what Chris has discussed there. And I think probably 20 years ago, I think historically when people did diagnose backs, it was all around sending for some sort of image. And then once you've got the image, you'd give a patient a diagnosis, and often they wouldn't have much hope after that, and they've held these beliefs for a long period of time. But I think what fascinates me, I know there was a study what was done in, I think it was 2012, where they imaged 2,000 individuals who were asymptomatic and they didn't have any lower back pain. And often these things what patients report, like disc bulges, degeneration, spondylosis, they were finding that people who don't have any back pain had all very similar things. And then I think that was one of the things we thought, actually, well, what is driving the pain?
So people with no symptoms of pain were scanned, and it showed all these kind of different things going on in their spines on the images, which sound quite scary, but actually these people have no pain.
Yeah, totally. And I think, totally. And I think I'm not underpinning the role of imaging, because obviously imaging is really important, because there is a small volume of patients where there is something sinister going on and they need to be imaged straight away and they need medical attention. And we do have a small percentage of patients where there is a patho-anatomical diagnosis and they need imaging, and then often they need the right sort of medical input. But that only probably accounts for sort of like 10 to 15% of patients. I think the rest of these patients have fallen into like what they call non-specific low back pain. And I'd never use that term of a patient non-specific because it plays it down, and probably what we talk about is multifactorial low back pain. But imaging for those patients where there's nothing suggesting that the imaging is going to change the management, this probably can be detrimental for things like yourself, because if you're told that information, what you were told, you've got a degenerative spine, I think I'd be probably quite afraid to maybe back.
Absolutely. Yeah. I think even in that, that 10-15% of people that you talked about, you're talking about kind of people who have maybe disc prolapses or something like that, which they'll get better anyway. Yeah. And there's I suppose if you drill down on that, there's a much tinier percentage of people within that will have, a spinal pathology that we'd be concerned about, like an infection or, something like that, or even a secondary or a cancer or something like this. Yeah. It's the reality is, it's, as you say, it's so incredibly rare, and the majority of people with back pain, they will have these changes, are fairly normal changes, the changes that we get in the same way that I once heard a neurosurgeon say that it's a bit like wrinkles on your face. We see changes in the spine as the years go past, and these are just normal changes that occur.
So if I'm kind of a patient, I've got, debilitating back pain, it's really impacting my life, it's a real struggle, and I'm thinking, God, I must need a scan, I need to know what's going on, I need to feel reassured there's nothing damaged in there. Like, how do you handle it when kind of people come in saying, I think I need a scan?
I think number one is give them a good listening to. I think that's the big thing, because I think giving them a good listening to, and then once you can sort of understand their pain a little bit better, perhaps giving them an alternative explanation of why you're experiencing this pain. And often when patients say they want a scan, you ask them, well, what would be different if I had a scan? And they would say, well, I want to be playing with my grandchildren a little bit more, I'd want to be getting back doing something in my life. And often you say, well, actually, I think we might be able to do that without the scan.
So sometimes finding out more about what someone wants.
What they want. I think the patient doesn't, they say they want the scan, but when you dig deeper, they want to be managing the symptoms better. They want to be doing more important
as well.
and reassured. And often, if you've listened to the patient, you develop that alliance. Often, the majority of patients, when you can give them an alternative explanation why they're getting pain, and if they understand it, I find the majority of patients seem to sort of get on board.
Yeah. And I think from the the biological point of view, if we think of like the biopsychosocial approach to pain, or pain as a biopsychosocial entity, the biological bits, clearly these are things that we don't really miss. We don't really miss in a diagnosis of something, and that's why I guess over the last 20 years there's been a lot of research focusing on how we can screen and how we can decide who does need imaging and who doesn't need imaging, and there's various questions that are hugely sensitive for picking up pathology in backs without necessarily needing to examine people. You can ask questions, and people who have spinal red flags, as they're called, it means really that we just need to take a bit more notice on. That may be that we need to do some blood tests, or it may mean that we need to do an image of the back. But that's kind of, I guess, how we've evolved with the evidence base for who needs to be scanned, because we know that when we go back 20 years and we'd image people with x-rays, the yield from x-rays is incredibly low. As you know, it's good for looking at bones, but it doesn't really pick up much to do with soft tissues. And so the information that we get from an x-ray is pretty poor. That's why we don't generally x-ray people. And also there's a big dose of radiation for a pelvic or spinal x-ray, because it's got to penetrate loads of thick bones. So it's a big dose. And so we've moved on to MR, I think, and that's a much higher yield in terms of information, but we're selective about how we use that scan. And you made a really important point, Graham, about sometimes scanning people unnecessarily itself is dangerous, because it can be interpreted or misinterpreted, and that can make people more fearful, and that's damaging.
And I think probably in this clinic, and especially a lot of patients we see with persistent spinal pain, a lot of them have been imaged over the years. And I think often the information they're being given, the enduring impact of that is massive. And I think,
in what way?
From a physio perspective, I think back pain, I think over the years when people have been told that the backs, or they've interpreted that the back is damaged, they treat it as if it's damaged. So when they sit, they hold the trunks really, really stiff. When they bend, they pull in the core muscles, they move really slowly, they check for the pain all the time. And often that's massively, massively provocative. I'd ask anyone today, bend your back and tense up, and even if you don't suffer with back pain, I bet you start doing that. So you're going to start getting some pain. And then I think that's about sort of creating what we call like safety learning. So teaching them an alternative way of doing this. And often that can be done when you do say, have you seen this cool study what was done in 2012 where it showed what's on your spine is really normal? And often that's like a massive relief to patients. No, I didn't know that.
So having a different understanding of why things might feel as they feel, and it not being equated with damage or your spine's damaged, that gives people a different story to tell themselves, and then they can behave differently around their spine, if you like, through moving differently, thinking differently, and feeling differently.
Totally. And I'd say as physios, it's not about saying this is the way you have to do it. How many patients I see sat in front of me every day and they're sat upright, and I said, well, why are you doing that? The physio's told me. How does it feel? It feels awful. What feels better? What feels slumped? Well, how come you don't sit like that? Well, I've been told it's dangerous. Actually, it's not that dangerous. That's how I sit. When we look at people who haven't got back pain, we all sit quite relaxed and chilled out, and the people with back pain,
a bit now.
and I think, it's patients to know that understand that, and I think the clinicians perhaps who've told patients that in the past, that's just where we were in healthcare, or where we were as a profession, but we've moved on.
So in the past I might have had the message, you've got a weak core, you need to strengthen it all up, and actually you're saying something different. You're saying actually see what helps you best, and you've noticed with people you work with, they seem to do better when they're a bit more relaxed and slumped around their movement and posture. Yeah,
totally. Like I said, it's asking them what feels better. That feels less pain. Sit like that. The back is incredibly strong and robust. You go to like third world countries where they don't see clinicians, they don't go to seek healthcare when they get back problems, and they're humping around the field doing all sorts, and the back's massively strong. Or we've seen like people with horrific road traffic accidents, and the only part of the body what's still there, what's not been injured, often the back and the pelvis. It's an incredibly strong structure. But over the years, we've created huge fear about it because I think it's the leading cause of disability.
I think we need to work hard as clinicians generally to not create these myths, don't we? I think we talk about osteoarthritis and we say well, of course you'll be in pain because you've got osteoarthritis in your back. And again, I was really interested to read the study that you alluded to before about the fact that all of these changes are normal, and we can expect these changes in people who don't have pain. We can expect them in people who have pain. So clearly, they're not the things that are the discriminator as to whether you're going to get pain or not. Yeah. So we need to work harder, I think, as clinicians.
So I think something we kind of commonly hear is, I've got this terrible back pain. I'm not on the right drugs. I need to come to the clinic, and I need to be on the right drugs.
Yeah, it's really common, isn't it? And I think it's the same for lots of different types of pain, isn't it? That there's a medication out there if we can just find it. It's a bit kind of like Cinderella, isn't it? If we find the right shoe, then it'll be a lot better. And again, the evidence for medicines generally in pain is really poor. We know that in acute pain, anti-inflammatories and paracetamol generally are things that might help. When pain becomes persistent and the mechanisms of sensitization start to kick in, they're not hugely helpful. Neither are opioids in the long term. We know that opioids for surgical type of pain or for acute pain, if you've had an injury or something, they may be useful. But in chronic pain, we know the overwhelming evidence is that they're not particularly helpful for sensitization. And the pain generally isn't responsive to, or generally isn't very responsive to that, and often you develop tolerance and end up having to escalate. The newer kind of take on drugs using antidepressant drugs or epilepsy, not because either somebody's particularly got depression or has epilepsy. We know that they change the chemistry a bit in the nervous system, but they're really blunt tools, I think, and we're talking about kind of fairly subtle changes in the nervous system sometimes. And these drugs generally, they're not subtle, and they usually carry lots of side effects. So I think largely, the old technology that we're using in medication, because there isn't really many new pain drugs at all that have come along in the last decade, our understanding of pain has come on loads, and so there are probably a lot more targets for drugs. But the old technology, it's just not particularly useful. And I think more and more studies are showing that now.
So what's the best evidence for low back pain? Where does the kind of way forwards lie, do we think?
Well, I think in terms of that, obviously, like Chris alluded to, the screening process happens first, isn't it? Where you exclude. And you never rule out a red flag, you remain vigilant, but excluding that type of stuff. But then I think it's this more of a, I don't know if it's pain management approach, but helping patients understand pain better. And I think we've got a growing body of evidence that patients can understand pain. And by changing their beliefs around pain can often reduce fear and often reduce pain. I think, for me, it's often then perhaps looking at movement patterns, improving patients' movement patterns, that they've developed these provocative ways of moving over years, and providing them alternative ways of moving, what often can be a little bit easier.
Sorry.
Yeah, no, go on.
What about when people come in and say, if I move it hurts, I just can't do anything. If I move it hurts. Yeah. How do we work with someone with?
Again, there's examples, I think, in other pain conditions. There's a pain condition called complex regional pain syndrome, where it's absolutely. I think a lot of pain conditions are hugely provocative and hugely difficult to move the area. Particularly in CRPS, it's we know from the evidence that's a real problem, and so we often bring it right back down to things like imagined movements. And it sounds weird to talk about this, but we know that the brain kind of uncouples the different processes that are necessary to make movements and to perceive things properly. So when we have that situation, it's so difficult to move. Even imagining a movement can sometimes start to rebuild some of the connections in the nervous system, and then you go on from imagined movements into recognizing different postures. In CRPS, complex regional pain syndrome, you sometimes do something called laterality training, where get to recognise what's left and what's right.
Mm.
So it's kind of challenging the brain, I guess, because we know the problem for persistent pain lies within the brain and how the nervous system has changed. And so we try and rebuild those connections and retrain the brain. We can do it really subtly, and then you start to move on to more graded hazards, which is...
That's really interesting, that, because I think that fits into sort of this relaxation and this, what I know there's growing body sort of evidence, but people using it more in pain management. Because like Chris was saying there, someone with back pain, just asking them to imagine bending your back, they tense up, the respiratory rate goes up, autonomic arousal, and it's perhaps changing how they respond to that a little bit. So like introducing things like belly breathing, slowing your breathing rate down, not only to I suppose take the focus away from the actual pain, but also changing what's actually our arousal levels. And we're finding that these, going back to some really simple things like slowing breathing down, can actually be hugely beneficial. And I know there's like things like mindfulness now, and I know that's something what we use in our clinic here with patients and stuff like that. And it's all about tapping back into that nervous system rather than trying to change something to a structure what can't be changed.
There's loads of evidence about polyvagal theory, about if you can slow your breathing down and a longer out breath, that kind of slows your vagus nerve, and your vagus nerve is the nerve that's connected to kind of everything, really, isn't it? Your heart rate and your brain and everything like that. So that's like a quick win in terms of affecting the physiology. So that then associating gradual movement with that safer kind of more relaxed body response, people can then maybe start moving a little bit more again, and pain's not ringing the threat bells as much, maybe.
And I think what's really good about that, often that can give a bit of control.
Yeah.
And like Chris, I think he said in an earlier video, when they're at home at 3 o'clock in the evening, 3 o'clock at night, and the pain's ramping up and I'm not there, they've developed skills to make them more robust, have more self-efficacy than doing it themselves. But these strategies of building up patients' sort of box of tools to say, yeah, I can deal with this. And when pain has been there for a long period of time, unfortunately, we can have flare-ups and stuff like that. But I think that's what...
And flare-ups do they mean it's not working, or like, you know, because people can feel quite despondent, can't they, when they're in a flare?
Yeah. And I think, you know, our understanding of flares again has changed a lot on it. And, you know, sometimes we think if a flare happens, or previously we may have thought if a flare happens, you know, that means there's something occurred structurally in the back, you know, either a disc has gone or, you know, slipped or something like this. And, you know, the reality is, for the vast majority of flares, it's really just something that's occurred within our pain system. It's just increased the volume control. It's just made it louder. And so when we know that that's, you know, the situation, then we can use all the strategies that Graham's just mentioned. And, you know, we can start to get better control of it. I think it's a long-term process, because at the end of the day, if the nervous system has changed over a long period of time to become so sensitized, it's not going to happen overnight to kind of recalibrate the nervous system. That's the thing that gives me such hope, really, when we're managing really difficult situations, really intense day-to-day pain, that there is hope to be able to recalibrate the nervous system.
And what I've heard is kind of, it's about, you know, us having some knowledge and understanding as clinicians, but also people having knowledge and understanding about themselves, and us valuing that and working together, and then people are ultimately kind of empowered to manage their own condition kind of effectively. One last myth before we finish. I don't know if it's a myth or actually something people often come across, really. People think I'm putting it on because my pain varies.
Yeah. I think, you know, in lots of pain conditions, back pain clearly one of them, but in lots of pain conditions, widespread pain, like, you know, maybe in fibromyalgia or something, there's a variance sometimes associated with that, and so people can go through periods of weeks or months where the pain is, you know, it's not quite as intense, it's still there, but it's a bit more manageable, and other times when it's absolutely, it's really difficult to manage, and sometimes that can happen over a daily or weekly basis, or even in the course of a day. And again, I think it largely, we go back to what we were talking about before, about how the nervous system can change. And sometimes when people reflect a little on pain, it may not always be the case, but sometimes you can start to recognise triggers. And you know, you talked before, Graham, about this really interesting concept when back pain is really problematic and people imagine movements, then it can flare pain. And so it kind of taps into how the nervous system's working. And so we know that flares generally are a consequence of that. And so it boils down, I think, to people fully understanding pain, and also partners and families understanding these mechanisms as well. Because this is hard stuff, isn't it? But when people fully understand why you get flares, then it makes it a lot easier to kind of manage.